this podcast. The pressures of this modern life, society, and world often steer us toward unhealthy lifestyles where wellness is a rare treasure hidden in a maze of daily challenges. In this podcast, we'll illuminate uncommon pathways to health and vitality, exploring cutting-edge ideas in regenerative, longevity, and performance medicine, all delivered in bite-sized segments of 10 minutes or less. I'm your host, Dr. Jamie Lewis, and today we're going to dive into a topic: does testosterone replacement therapy cause prostate cancer? Well, this episode is brought to you by Center for Regenerative and Performance Medicine, located in the beautiful Pacific Northwest. Visit us online at www.c4rpm.com. Before we begin, a quick disclaimer: this podcast is for educational purposes only and not intended as medical advice. Always consult a qualified healthcare professional for any medical concerns or treatment. At Center for Regenerative and Performance Medicine, we routinely recommend hormone and metabolic optimization for our patients to improve their overall health, healing, and vitality. After recommending testosterone replacement therapy for a middle-aged man with clear signs of androgen deficiencies, I received an angry phone call from his primary care physician, concerned that I was recommending a treatment that would cause prostate cancer. Now, although this physician claims to be practicing evidence-based medicine, clearly we're on different wavelengths. This mixed messaging can leave patients discouraged and confused. I thought it was important to have an episode to review what the science actually shows on this topic. So let's start with a couple truths. Number one, testosterone and androgens can fuel the growth of existing hormone-sensitive prostate cancer, especially in advanced disease. And that's why androgen deprivation therapy is a cornerstone of treatment in metastatic recurrent prostate cancer. Truth number two, however, is that the claim that physiologic testosterone replacement therapy causes new prostate cancer is not supported by the best available clinical evidence in appropriately selected and monitored men. The real question is, does restoring testosterone from low to normal levels create prostate cancer or drive dangerous progression in men we treat? Well, the American Urological Association states that clinicians should inform patients of the absence of evidence linking testosterone therapy to the development of prostate cancer. Now, the American Urological Association also adds an important nuance. For men with a history of prostate cancer, there is inadequate evidence to precisely quantify the risk and benefit ratio. So this becomes an individualized decision with careful monitoring. That's not the same as to say it's unsafe. It's a statement about the limits of certainty and the need for shared decision making. One reason this conversation has shifted is higher quality data for more standardized monitoring. In large randomized data sets with adjudicated prostate outcomes, like the analysis within the reverse trial program, prostate cancer events were uncommon and did not show a clear signal of increased high-grade disease in testosterone-treated group compared to placebo in screened men under structured PSA monitoring. The key caveat is high-risk men were excluded, and low event counts can't prove zero risk, but the findings substantially reduce fear of a strong causal effect in typical candidates. Well, what about men who already had prostate cancer? This is the part that most people don't realize. Multiple reviews and clinical series have evaluated testosterone replacement therapy in men after definitive prostate cancer treatment, such as prostatectomy or radiation, looking for biochemical recurrence or progression. A major European urological review summarized that men receiving testosterone therapy after treatment for localized prostate cancer do not appear to have higher recurrence rates or worse outcomes, while emphasizing limitations in study size, design, and the need for careful selection and monitoring. And in the clinical literature, you'll see multiple cohort series describing post-prostatectomy and post-radiation where recurrence rates remain low in appropriately selected men, including reports involving investigators like Petsurek and others. Importantly, these studies are not saying that TRT is risk-free for everyone, but they support a more accurate statement that in well-selected, closely monitored men with treated localized prostate cancer, testosterone replacement therapy has not shown increased progression or recurrence signals. The biological model that helps make sense. One landmark tissue-based study supports the concept that when testosterone is raised from low to physiologic levels, changes inside the prostate are minimal, supporting the idea of androgen receptor saturation, i.e., beyond a certain point, additional testosterone doesn't keep increasing prostate stimulation in the same way. Now, that doesn't negate that androgen deprivation therapy in advanced prostate cancer. It explains why restoring testosterone to normal isn't equivalent to pouring fuel on a fire in men without active disease. Here's how to think about this clinically. Testosterone can stimulate existing prostate cancer, which is why testosterone replacement therapy is generally avoided in active, untreated, or advanced disease. But the statement testosterone replacement therapy causes prostate cancer is not strongly supported when TRT is used to restore physiologic testosterone levels in appropriately screened men. In men treated previously with prostate cancer, published data and case review series generally show no clear increased risk of recurrence or progression. Of course, monitoring is not optional. One should receive a baseline PSA test and follow-up PSA tests, which should be trended, and CBC and hematocrit and symptoms should also be monitored. Medicine evolves, but outdated myths persist and patients pay the price. The unsupported belief that testosterone therapy causes prostate cancer has led to many men to be unnecessarily deprived of treatment that can meaningfully improve energy, strength, bone density, metabolic health, mood, sexual function, and overall quality of life. Left untreated, testosterone deficiency contributes to frailty, insulin resistance, loss of muscle and bone, and worsening cardiometabolic risk with declining function as men age. Our responsibility as clinicians is clear: to not practice fear-based medicine, but evidence-based medicine, using proper screening and thoughtful patient selection and vigilant monitoring to ensure safety, to restore physiologic testosterone levels, and allowing men to age with strength, resilience, and dignity. Hey, thanks for joining me today on the Rare Wellness Podcast. If you found value in today's episode or learned something new, please subscribe, leave a review, share this podcast with a friend. Your support helps us to continue to provide free content to empower you on your journey to better health. This is Dr. Jamie Lewis reminding you that your body holds the incredible potential to heal, thrive, and perform. Sometimes it just needs the right tools to unlock its full potential and help you live your best life now. We'll see you next time.